Hello again. So this is part 3 of the lecture. Now we were talking about postmenopausal bleeding, and I was saying that so the main condition which we have to rule out if a woman presents with postmenopausal bleeding is endometrial cancer. Although the chances of having it is just 10%, but still. And then sometimes, despite all investigations, we cannot find the what is causing abnormal uterine bleeding. Right? Apparently, everything may be fine, even though if we do cervical screening, if we do ultrasound, if we do even hysteroscopy, so everything may look fine, normal, but still the woman may complain of abnormal uterine bleeding. Okay, that condition is now called BEO, bleeding of endometrial origin. It's actually a diagnosis of exclusion, which means that like we have ruled out everything. Previously, it used to be called DUB, dysfunctional uterine bleeding. So everything looks fine, but still she's having abnormal uterine bleeding. Now, what I'm going to tell you, it's only related to heavy menstrual bleeding. We have separate lectures related to cervical cancer, so which will deal with postcoital bleeding. We have a separate lecture for fibroids, a separate lecture for endometriosis and adenomyosis, and even pelvic inflammatory disease. Okay, so in heavy menstrual bleeding, remember when we talked about normal menstrual cycle, we said that so there are different parameters. When we are taking history, one of the parameters is assessing the volume of blood loss. So if the volume is heavy, it's a lot, then we call it heavy menstrual bleeding. Now, how much is that heavy or a lot? That's the cutoff is 80 mils per period, okay? But to be honest, no woman or no doctor measures, right? So in clinically, when a patient says, I'm having heavy bleeding, we just rely on that information. It's not objective, it's subjective. And so we never know whether she has reached that 80 mils or not. How can we kind of try to investigate by history? For example, yes, to assess how severe it is, yes, we ask how many pads do you use per day? Are they like full? Do you pass clots? Do you feel weak? Do you feel dizzy when you are having a period? Does it leak through undergarments and garments? And do you have shortness of breath? Like that actually for anemia, right? So anemia is secondary to blood loss. And do you feel weak and dizzy, right? So this is just kind of, we are trying to do it subjectively. We don't do it objectively. Another way is to just request a complete blood count to assess hemoglobin levels. But again, that's unreliable because even until and unless we had her recent hemoglobin level previously, we won't know, because previously she might have had a hemoglobin of 14 and now if it's 12, we will say, oh, it's normal. But actually, she might have had lost a lot of blood, right? So it's kind of, even assessment of hemoglobin is maybe not too reliable. Okay, when if it's normal, yes. If it's low, then of course yes. Okay, that means she has lost a lot of blood. So it's mainly a clinical diagnosis. Okay, now what are the causes of heavy menstrual bleeding? So 30% of heavy menstrual bleeding, it's caused by fibroids. Now remember that there are different types of fibroids. So in the uterus, we can have, depending on the position, they can be outside the uterus, which are called the subserosal fibroids, or they can be in the wall of the uterus, which is called the intramural fibroid, or they can be in the endometrium, like protruding into the cavity of the uterus, which is called the submucosal fibroid. Now, do all kind of fibroids, they cause heavy menstrual bleeding? The answer is no. Okay, and sometimes we have cervical fibroids as well. So do we have all kinds of fibroids cause heavy menstrual bleeding? No. Subserosal, which are outside the cavity of the uterus, they do not cause it. Okay, again, I'm telling you, we have a separate lecture on fibroids, so I'm not going to go beyond that. Okay, another condition may be adenomyosis. So adenomyosis is usually, these are middle-aged women. Okay, so usually they are multiparous, and they, in history, they present with secondary dysmenorrhea and dyspareunia. Okay, deep dyspareunia. Now, Dyspareunia means having pain during sex. There are two types of dyspareunia. We talked about dysmenorrhea already. Okay. So dyspareunia, if it's superficial or deep. Okay. So in adenomyosis and pelvic inflammatory disease and endometriosis, there is deep dysmenorrhea. Okay. So that means in the later part. Okay. Not superficial. Then endometrial polyp. So usually endometrial polyp can present as intermenstrual bleeding, but yes, it can present as heavy menstrual bleeding with intermenstrual bleeding as well. Coagulation defects. So especially if young girls, if they're presenting with heavy bleeding, because that might be the first time we are investigating them. Okay. So yeah, it can be anything like von Willebrand disease or hemophilia carrier or platelet functional disorder. Okay. It can be pelvic inflammatory disease. It can be thyroid disease. Now remember, mostly it's hypothyroidism, but it can be hyperthyroidism as well. Then different drugs can cause heavy menstrual bleeding, right? So if a patient is on anticoagulants, for example, okay, in gynae, especially we have to take contraceptive history carefully because intrauterine copper device causes heavy menstrual bleeding, okay? So yeah, that's the next one. So intrauterine copper device, and then sometimes it can be something more sinister, something more serious, like cancer, right, of the endometrium or cervix. Okay. So in history, basically, we will practice this on a simulated patient as well. But yes, we always should know the age of the patient, right? Age just tells us a lot of things. When was the age of menarche? Why are we interested? Because if a woman has been having heavy period ever since her menarche, that means it can be even a coagulation defect, right? Marital status is she sexually active? So because we always, any as a rule, any change in the pattern of uterine bleeding, vaginal bleeding, always rule out pregnancy and pregnancy related complications. Okay, what do we mean by pregnancy related complications? It can be even a molar pregnancy, right? It can be even a choriocarcinoma. So something which can present even like all of a sudden, right? So she can have a choriocarcinoma, she can have a molar pregnancy, she can have an incomplete miscarriage. And remember that many of pregnancies, they are unplanned. Okay. So all of a sudden, even if they are using contraception, no contraception is 100% protective, right? They have failure rates, even if they had tubal ligation, for example. So in that case, we always have to rule out. We should know, like, is there any possibility of pregnancy or pregnancy-related complications? We have to ask about dyspareunia, dysmenorrhea. Why? Because we have to rule out endometriosis, adenomyosis. What is her parity? So if she has delivered children before, we can ask about the history of postpartum hemorrhage because it may be a coagulation problem. Contraception, because if especially if she's using hormonal contraception, as a side effect she can have been having heavy menstrual bleeding like intrauterine copper device. Okay. When was her last period? What is the duration of her cycle? Are her periods regular? Because if they're irregular, then we think about all of these conditions like polycystic ovaries, thyroid problems, early puberty, or extremes of reproductive age group, right? And then what is the volume lost? So what is the number of pads used per day or tampons? Does she pass clots? Does she faint? Does she have dizziness? Has she experienced shortness of breath? Okay, and related to her treatment, especially because there are different treatment options. So we always should know her desire for future fertility. Okay. So how many children does she have? How many surviving children does she have? Does she want to get pregnant and when? Like, okay, near future or maybe in few years. Okay. So then medication, current medication, any known medical conditions, when was her last cervical screening was performed and what were the results like? Excessive bleeding after dental procedures or surgeries, so that's when we are suspecting coagulation problems. Family history of bleeding disorders, unusual vaginal discharge because it may be pelvic inflammatory disease. Pressure symptoms, so why we are talking about pressure symptoms? Because if there are big fibroids, right? So they may compress on the surrounding organs like bowel, back, urinary bladder, and they may cause pressure symptoms. So what can be the pressure symptoms? If it's a big thing, big mass in the pelvis, it can obstruct venous return from the legs and it can cause pedal edema. Okay, so as a rule, any patient who complains of a lot of swelling of the legs, always think about a pelvic mass. Okay, because some patients may not have noted abdominal distension, but they may present with swelling in the legs. Yes, it can be heart failure. Yes, it can be liver failure, like something related to liver or kidneys, but always think about it can be a pelvic mass, right? Which is obstructing venous return from the legs. Okay, there may be backache, because if it's a big fibroid in the posterior wall of the uterus and it is compressing on the back, it can cause backache. Pain in the lower abdomen or fullness or feeling bloated. Now, this feeling bloated is a serious, may be serious, especially in women who are more than 50 or even 40, because usually ovarian cysts or ovarian cancers, right? It's one of the presenting complaints of ovarian cancer. Okay, so it may be even large fibroids, urinary complaints, a weight change. So all of these are related to hypothyroidism. If there is weight gain, there are skin changes, fatigue, feeling cold or hot. So cold in hypothyroidism, hot in hyperthyroidism, excessive eating in hyperthyroidism, anorexia in hypothyroidism. Also something, if it's cancer, then women lose weight and they have loss of appetite, insomnia and sleepiness. Okay, insomnia in hyperthyroidism, sleepiness in hypothyroidism. So I'll stop here and then